So, good afternoon and welcome to this afternoon session in thoracic surgery. This session is COVID infection, something that I'm sure we've all had a more experience than we would have liked over the past year, but an important session, I think, given that to look at experiences. So, it gives me pleasure to introduce our first speaker, who is Stephen Cassidy from the Mayo Clinic in the US. And the topic of the talk is COVID-related changes in medical practice. Are these going to stay?
Thank you to the Society for Cardiothoracic Surgery, Great Britain and Ireland for the opportunity to contribute again to your annual meeting. I've been asked to present to you a perspective on COVID-19 from a thoracic surgeon in North America. What will likely persist, must change, or finally dissipate, as we all hope this virus will too. It's an honor to be back with you, although the back is a virtual term, given this global crisis. I'm nevertheless grateful for this opportunity to be with you, my friends and colleagues from the UK and Ireland, if only virtually and for a short time. I have no financial conflicts of interest to disclose. My only disclosure really is to say that while many of you know that I am Canadian, over the past 20 plus years of living here in the US, I have enough United States baked in that I will certainly be giving a mostly American perspective. I will also note that much of the facts and figures that I will present today come directly or indirectly from the United States' most respected and experienced scientist in the area, Dr. Anthony Fauci. Although he had many obvious national obligations, Dr. Fauci also found the time and energy to be a guest lecturer in my daughter's biology course at MIT. And so I've had the privilege of listening in online to some of his teachings to them. One of the earliest medical adaptations with COVID was the development of a new visual pain scale based on Fauci himself, and with good reason. When I was first invited to give this talk by my good friend and colleague, Maninder Kalkat, the global map, and indeed the US map of virus prevalence, was much different. Here we have the map in the early days of the US in March of 2020, the Ides of March to be exact, with all the Shakespearean implications this assembly today is best suited to understand. Although we were told by our then president that the virus would perhaps rise to 15 cases and then miraculously disappear, in 1 month, this was our test positivity across the country. We began then on a state-by-state decentralized way. Since there was no recognizable national plan, we began work on isolating, working from home when possible, social distancing, and mask wearing. But the message from our national leadership, if I am to be polite, was inconsistent. 2 weeks after our July 4th national holiday, we had returned to significant outbreaks and test positivity. As you can see from this graph, in the US, we did not sustain the flattening of the curve. The inconsistency of message, lack of federal plan, as well as other factors, such as mass public protests and gatherings, led to an earlier and more pronounced spike than you experienced in Europe at that time. And then again, in the late fall and early winter, we faced yet again a surge of prevalence and hospitalizations. By late November 2020, only Hawaii, by definition isolated as a group of islands in the Pacific, only they did not show uncontrollable spread. But what have we done at Mayo Clinic during this pandemic? Well, to put it modestly, it's been a learning experience. This was one of our thoracic surgery division meetings. I'm certain that this Zoom format looks familiar to all of us doing meetings these days, even like this conference, by distance. When the definitive alarm bells went off in March 2020, Mayo Clinic did take a significant step back. We took counsel in the respected authorities, the World Health Organization, the National Institutes of Health with Dr. Fauci's leadership, and in surgery at Mayo Clinic, we sought understanding from our other colleagues, including many of you here. We curtailed surgical procedures initially, back to basically only emergent cases with allowance for only selected oncologic cases, meaning that for the first 3 weeks, we were only able to do about 10 thoracic cases per week. This reduction was implemented to preserve capacity in our ICUs or ITUs. We instituted mandatory COVID testing for all elective cases and limited staffing in the operating rooms to minimize exposures. All trainees except for surgical residents were not permitted in the OR. And in an effort to limit aerosolization of virus, we put filters on our pleural drainage tubes. By April, having not experienced the same surge as on the East and West Coast, as well as having experienced no notable adverse COVID-related surgical events, we cautiously expanded our surgical volume. By mid-May, we were basically back to full schedules and trying to assist with some of the volume from other centers who were not able to proceed because of regulations or capacity. By year's end, in terms of surgical volume, we were very fortunate to be only 11% below our 2019 volumes. In terms of working at a distance, we were very fortunate too to have a relatively robust experience and burgeoning infrastructure in the area of telemedicine. And it's because of this. We're in the literal middle of nowhere. This is a depiction of the distances of my thoracic surgery patients, with a third coming from within 500 kilometers, a median distance of 800 kilometers, and 1/3 coming from beyond 1,600 kilometers. With this distribution, you can see that bringing people back for what is usually an anticlimactic follow-up visit can be challenging and frankly inefficient. Here are those same distances plotted around the Midlands for perspective. Because I felt strongly about surgical follow-up, a number of years ago, I partnered with our Center for Innovation at Mayo Clinic to develop a web-based communications platform that was secure, user-friendly, and integrated with our electronic medical record and patient portal. Over time, it has evolved. And over the years, we set up standards and ironed out many of the early wrinkles, such that we developed experience and a comfort level for both us and our patients. This is a cohort of our first few years of patients, a standard mix for a thoracic surgical practice. In that first cohort, we saved over 500,000 kilometers in travel, or just over 13 circumferences of the Earth. From a safety statistics standpoint, you can see that for every 1,000 patients seen by video visit, actuarially, we avoid 1 serious traffic injury or fatality. From the environmental standpoint, just in our first cohort, we saved over 90 metric tons of carbon dioxide emissions. Now I don't feel as bad when my laparoscopic cases go longer than anticipated. Furthermore, the median length of surgical follow-up visit ends up being somewhere around 7 minutes. So well before the pandemic hit, we had published on the benefits and even an in-depth economic analysis of video follow-up. That was our lead-in with post-op follow-up by video. What about the initial consultation, previously prohibited due to interstate licensure issues? While the exigencies of COVID, however, created a need for access that allowed loosening of the current regulations, allowing us to confer and even with first consultations, do a video visit with patients across state lines. This is my cohort of initial consultations since the regulations changed because of the pandemic. The demographics are remarkably similar. The distances have slightly dropped, but are still in the very similar ranges. The median distance is 443 kilometers, or the distance from London to Middlesbrough. A tip of the hat to my colleague, Joel Dunning. The duration of the consultation is understandably longer since it's a first initial visit, but still remarkably reasonable at around 20 minutes. And the distance we save for these first 89 patients is just under 3 circumferences of the Earth. Other aspects to understand and consider are that those seen, 80% had an indication for surgery, and of those with an indication, 94% came to Mayo Clinic for their surgical procedure at a median interval of 20 days from their initial video consultation. This demonstrates that once you meet with the patient, even by video, you can develop a meaningful bond that is usually sufficient to have them travel for their surgical care. So in my closing moments, I don't have any more clairvoyance than any of you. My sense, though, is that we're making sufficient and significant improvements in curtailing the tragic and devastating effects of this virus through vaccine dissemination and continued public health measures. When will we emerge and how that will look remains to be seen. Hopefully, we will have learned from this global calamity, and some of that learning will be in the surgical domain. I do believe telemedicine will shrink distances and provide access to experts for otherwise isolated and underserved populations. What is impossible to overlook, though, are the significant racial, ethnic, and socioeconomic disparities uncovered when considering the severity and devastating effects and human costs of COVID-19. Which brings me to a book that I highly recommend, even if you're not a football aficionado. It has lessons on understanding the game, but more importantly, if one digs deeper on understanding the world, it breaks down sports into strong link sports dependent on a singular star for success, like basketball. The team and its success is defined by its central star. And weak link sports, like football, which depend on a higher level of team interaction, where the team is more defined by its weakest player and where the singular star cannot carry the team alone. What our current pandemic has shown us is that we live in a highly complicated, highly interconnected, and highly interdependent world. In other words, a weak link world. The pandemic uncovered our interdependencies and exposed our numerous vulnerabilities and how poorly we have paid attention to them. The pandemic has exposed how we spend all our attention on the 99th percentile and not enough on the 50th percentile and below. All of the exotic therapeutics machinery are not what we needed or remarkably still need. Of course, we benefited from the high-tech solutions to expediting a vaccine, but we clearly needed more nurses and simple supplies like masks and gowns, as well as access to care. We have to be careful in our aftermath of the COVID-19 pandemic that we don't fall into the trap of most historic events that fill our libraries, that the history is written by the victors. It will be unfortunately very easy for those of us who have survived COVID-19 to downplay the catastrophic loss of life, over 3.3 million deaths worldwide to date. This should not be downplayed as just some culling of the herd, that the weakest weren't able or even meant to survive, and that those who did survive did so because we were somehow stronger or better. What it should truly make us think about is how we've structured society such that the vulnerable are indeed so vulnerable. And we do this at our own peril, since one of the biggest lessons of this pandemic is that we are all interdependent. There is thankfully hope on the horizon beyond the current storm clouds. We have new leadership in the world that recognizes the true nature of our current situation and their responsibility to act and to lead, and the importance of giving science its place at the policy table. We also have the promise of vaccines. And then we must plan, restructure, and prepare for the next global crisis and how we will manage it together better. Thank you for this opportunity to be with you again. I look forward to the discussion.
Thank you, Stephen. It was certainly a very thought-provoking talk and an interesting look at what's been happening in the US. And I particularly enjoyed your Tottenham analogies. So we move on now to questions. Encourage everybody to ask questions. The first one is around fitness. Did you get an idea of fitness for surgery by video, or were patients referred who had already had tests such as CPEP, 6-minute walk, shuffle tests?
It's a great question. I think the benefit of video is it allows us to see patients. It's face-to-face as opposed to in-person. So it's definitely not as good as in person. But Mark Ferguson, one of the thoracic surgeons here in North America, has done a lot of research, actually good objective research on being able to identify frailty with the observation, the end of the bed sort of test. And we do get a sense of that with video. But obviously, when we bring patients to Mayo for the operation, if it's been deemed indicated and the sense is that they're fit for it, we do see them when they get here to have an in-person visit the day before their surgery. So they're scheduled for surgery. We see them the day before the surgery, and it kind of works out well now because we're obligated to get a COVID test before bringing them to surgery. So they have their COVID tests in the morning. We see them in the afternoon, confirm that they're candidates for surgery, and then bring them to surgery. So it's a good first triage. And those that don't have those tests or the tests that are necessary can get them done the day before surgery. Yeah.
Great, thank you. And another one around the video consultations, perfect presentation, saving time in transportation, reduction in CO2 emissions. Do you think this will become the standard practice long term, even outside of a pandemic?
Yeah, I really do think this is one of the things that the pandemic has opened our eyes to, the opportunity. We were well placed because we had some experience with it for follow-up. But I do think that this is going to allow people to confer with experts and save distances. It's going to help people who are isolated or who don't necessarily have access. And I hope it expands and democratizes our access to experts in the field.
Can I ask a question? Congratulations for fantastic organization of this video link. I think you need to rely on your chest physician and referring. Do you have a list of examination, unified list, which they need to present you? Because you need to really rely on a good cooperation with your chest physician.
Often you do, but most of, to be honest, the vast majority of these patients are self-referred. You know, they've been told by their local doctor that they need to see a thoracic surgeon, and they decide, well, I can't get into my thoracic surgeon here, or I'd like to seek another opinion, and so they are coming our way, because this is a decentralized way of seeing patients. So I don't necessarily have a stream of patients coming from one referrer or another. We certainly have our referrers who do that, but this is a patient. These are onesie twosies from all over the United States.
So you need to have a very well organized on admission, because you need to do all the tests. Everything is done on admission. They're coming with a very initial diagnosis.
Yeah, one of the benefits that we have, and I know you trained at Barnes, so you understand that that it can be done if properly incentivized. Having a system that is organized and around getting the patient the tests that they need. So we're very fortunate. I know that's not the case everywhere, but we're very fortunate to be able to organize the tests in a way that they can be done expeditiously when the patient arrives. Part of the reason, too, to be quite honest, is we recognize that Rochester's not London, it's not Edinburgh, it's not Paris. It's a very small town, and we don't want patients to have to spend a lot of time here because it gets boring. So we expedite their tests here.
Thank you.
Great, thank you. I think we're running a little short of time, but just one final question. How did you select the weakest player at Spurs, given the competition?
Yeah, I'm understandably, I'm a self-deprecating Spurs fan, so it was not easy to pick, but Eric's always there. He takes the brunt of it. Thanks for understanding a little bit of a joke there.
Lovely. Thank you again for an excellent talk. I think that's been really eye-opening. Thank you.
So our next presentation is on the VELOF screening protocol for thoracic surgery during the COVID-19 pandemic. It will be presented by Alan Dawson. I would encourage the audience to post their questions and also kind of rate the presentation when the polls get open. So the presentation from Alan Dawson.
Chairpersons, ladies and gentlemen, thank you very much for the opportunity to present this work on the value of a screening protocol for thoracic surgery during the COVID-19 pandemic. My name is Alan Dawson, and I'm one of the cardiothoracic surgical registrars at Glenfield Hospital in Leicester, and I'm a PhD student at the University of Leicester. Now, it was on the 23rd of March last year that Prime Minister Boris Johnson placed the United Kingdom in its first coronavirus lockdown. Whilst the general population were told to stay at home, the NHS had to continue to provide the best possible care to patients. That was the best possible care to those affected with COVID-19 and to those patients requiring care for other conditions. This had to be balanced against the risk of overwhelming the NHS, and therefore a rapid transition was required. But how that transition should happen was not subject to any guideline. And therefore, our thoracic surgical department developed a screening protocol for patients with the aim of allowing the provision of safe care and to allow cancer work to continue to prevent the backlog that would ensue if the service was to stop. Now, this is a flow diagram looking at the patient pathway from admission through to discharge. And patients that were identified for surgery underwent a pre-admission COVID-19 nasal and throat PCR swab 3 days prior to admission. If that was negative, patients were invited into hospital and underwent a pre-operative CT chest to look for COVID-19 related change. And if that was negative, then patients proceeded to have their operation, and at the time of the operation had a bronchoalveolar lavage to detect COVID-19. And then during their post-operative stay at predefined time points, further COVID-19 nasal and throat PCR swabs were obtained. Now, between April and August of last year, which was the coronavirus first lockdown, 201 entries were entered into the database, and that dropped down to 189 because 7 notes were not available for review, 4 patients had been cared for by another specialty, and 1 had no information that we could obtain. This then dropped down to our denominator of 172, with a further 17 excluded because of cancellation. Now, here we can see that the most common reason for cancellation on the right-hand side of the screen was lack of theatre time, and this really reflected the increase in time between patients coming to theatre that we had to observe. The second most common reason for cancellation was the CT scan at baseline actually showed improvement, and that was an unexpected finding of this work. Now, this table shows the patient demographics, and we can see that the majority of patients were male with a median age of 67 years, and the number of patients operated on was 144. Now, using the different detection methods, we yielded 1 positive result from the pre-admission nasal and throat swabs, 1 positive result from the CT scan, and 2 from the bronchoalveolar lavage. The median number of post-operative swabs was 1, and that yielded 5 positive COVID-19 results. So in total, we had 9 positive results affecting 5 patients. And to look at those 5 patients in a little more depth, they formed 3% of the total cohort that we studied. 4 were male, the median age was 49 years, and no patient required intensive care unit stay. The length of hospital stay was significantly longer in those with COVID-19 at 10 days compared to 6 days in those who were COVID negative, and no in-hospital COVID-19 related deaths were recorded. Now, when we look at the complications, we can see that the top 3 most common ones were prolonged air leak, blood transfusion, and blood and talc pleurodieses. Intensive care was required for 7 of those patients, which amounted to 4%. So, chairpersons, ladies and gentlemen, in conclusion, our COVID screening protocol during the first wave allowed us to continue to provide a safe service for our patients. In total, 5 patients, or 3%, developed COVID-19 infection, and those patients did have a significantly longer hospital stay. No patient required intensive care, and none died whilst in hospital. The most common complication was related to chest drain management, and a lot of that was due to the concern raised over aerosol generation from the underwater seals off suction and the Portex drains, which were restricted in use. And we conclude that this screening protocol allows for the provision of safe care for patients and is fit for purpose. Thank you very much.
Thanks, Alan. A really interesting presentation. Whilst we're waiting for questions from the audience, may I ask you a question? So obviously this was during our first lockdown. So how do you, now that we are coming coming out of the second lockdown and the number of cases are really low, do you still require swabs and CT scan for all of your patients, or have you now changed the protocol that you use?
Yeah, so that's a very good question. So you're right, we've come out of the first lockdown and we of course went into our second lockdown, which for Leicester and the majority of the country was bad. And we suffered more in the second lockdown than we did in the first. Now, with regard to how we continue to manage, the COVID situation, we do still do the pre-admission swabs in all patients, and we still do continue to do the bronchoalveolar lavage. However, after the first wave in the first lockdown, CT was heavily scrutinised both by the radiology department and by us, and we can see that in our cohort of patients, CT yielded very little in the way of COVID. It's different when you look at how patients had improved conditions, which was, as I said, an unexpected finding. But the radiology department and the radiology guidelines subsequently stated that CT doesn't offer any benefit to patients, and therefore during the second lockdown CT was not incorporated. The only way that we would get a CT now and during the second lockdown was on the basis of disease progression, or if the CT had run out of time. Oh, I think you're muted.
Sorry. Yep. So the question from an audience, low mortality is different to the other published series. So were these all resections, the cases that you presented in your series?
So there was no exclusion based on the case mix that we recruited during that time. Now, of course, our mortality is low, but you could argue this for several reasons, because our COVID-19 rates are significantly low. But then again, these are patients with lung conditions, and by nature, they're going to have strict isolations, and certainly a lot of our patients, were very much staying at home. Now, Leicester are very well renowned for malignant pleural mesothelioma surgery and also for lung volume reduction surgery. Did we do those during the first lockdown? No. We did one EPD during that time. That was a trial patient, but the LVRS all got pushed back. So the actual case mix in terms of the disease that we're operating on, and also performance status, because you can see the vast majority were in 0 and 1. And really the 3s and 4s and above came from emergency work, especially with airway narrowing and stenting. That really formed your group that you would require. With regard to the case mix as well, we had to be very, very careful, because we didn't want to overwhelm the NHS, and we certainly didn't want to overwhelm intensive care. So therefore, we had to, select the patients that we thought would proceed without the need for intensive care. And I suspect, although we never looked at this, a lot of patients went on to have oncological care first before they came for surgery. So that will undoubtedly have an effect.
Okay, so I know we're running a bit of time, but I want to ask this last question, which came from an audience. What have we adopted as a change to deal with the chest drain, underwater seal chest drain issue in regards to COVID? Yeah,
so that's something that's been up and down during the time, and certainly during the second wave and up until now, we're starting now to put drains of suction. With the recognition that the actual rates of aerosol generation and COVID-related risk is much, much lower. We went through a time period as well where we've got a fantastic physio support team in Leicester, and again, all the physio work was done in an isolated room that was segregated off. That's now changed, and we're able to do the physio a bit more freely. So I think with us having gone through the first and the second wave, we've identified that we can do these things safely going forward.
Okay, thank you, Alan. That was a really nice presentation.
Thank you very much.
So it's my pleasure to introduce Kaan Hamad, who will talk about implementation of preoperative COVID-19 testing, allows safe configuration of surgery in tertiary thoracic surgical unit.
Hi. My name is Ahmad. I'm one of the core surgical trainees at Liverpool Heart and Chest Hospital, and today I'll be discussing the thoracic COVID-19 screening audit. A little bit of background. We all know the COVID-19 pandemic has really hampered all elective surgery. A paper published by COVID Surge in The Lancet during the time suggested a higher mortality rate in those patients that contracted COVID and underwent surgery. Another paper, more recently published by COVID-Surg in the Journal of Clinical Oncology, suggested a lower mortality rate in those sites where there was COVID-19 free surgical pathways. Our methodology, our main aim was to try to compare our experiences and practices before and after implementing policies. And this was a retrospective analysis and collection of data. There were some actions that were taken, such as stopping surgery for 10 days, regularly engaging in MDT and referring hospitals, and urgent policy changes, such as ward segregation and pre-op screening. Now, this pre-op screening included bringing the patient in 3 days prior to surgery, and then having some investigations such as CT scan of the chest, nasal swab, and blood tests. They also had a bronchoalveolar lavage performed during the procedure. This, however, changed, as you can see, during time. Now, the results. The pre-screening era was in March. We had 105 patients. Unfortunately, had 5 mortalities. All the patients that tested positive for COVID in this group all passed away. During the screening era, which was from the start of April to the end of June, there were a total of 136 patients, and we had 2 mortalities. The p-value was 0.13, which was not significant. Coming to investigations, we start with COVID-19 swabs with a total of 135, and only 4 came back positive. CT scans, a total of 121. 4 were labeled as positive. It looked like this. 10 were labeled possible, and a scan looked like this. Whereas a total of 107 were labeled negative. Bronchoalveolar lavage, a total of 69 patients underwent this, whereas only 6 came back positive, all of which had a negative swab and no changes on their CT scan. Coming to the chest x-rays, 11 patients underwent a chest x-ray, with 1 being labeled as probable, and this looked like this, and a total of 7 labeled as negative. There were 14 cancellations, of which 12 were due to COVID. There was 1 due to a confused patient, and 1 being referred to palliative care. Of these, 12 were readmitted after a period of quarantine. 1 was, however, cancelled due to a repeat positive swab, whilst another later on in the study underwent surgery despite having a positive swab after discussion with virology. As you can see, there were a total of 22 complications, which is 29% of our group, and a majority of them had a chest infection, whereas there was a clear distribution of 9% between pneumothorax, AKI, UTI, and AF. Coming to our length of stay, which was a range of 0 to 70 days, and a median of 3 days. We also did a length of stay for BAL positive patients, which was 3 to 9 days, and a median of 5 days. Coming to our mortalities, we had 2 post-op mortalities. 1 tested positive for COVID-19, deteriorated 2 days post-op, and died 10 days post-op. 1 tested negative for COVID-19. This was, however, a high-risk patient and died 11 days post-op. In conclusion, it is safe to continue lung cancer surgery during the COVID-19 pandemic with appropriate policy changes such as ward segregation and pre-op screening. It was clearly evident that protocols on how to manage thoracic surgery patient was really important. We were able to operate while keeping infection rates low, and this also brought up the importance of an up-to-date CT scan, which can help alter management if needed. We also changed advice to our patients on discharge, such as contacting the department in case of deterioration or need for admission. Thank you.
Thank you very much for this interesting presentation, and congratulations to maintain the surgical activity in this difficult time. especially what, on the basis of your experience, what will be your recommendation now for what selection and test we should do now? And what was the experience? I see you operate 12 patients post-COVID 2 weeks after surgery. Would there any specific recommendation or any specific complication you encounter?
I think with our cohort of patients, we had a pretty good experience, and what we would still recommend, or what we're still doing, is we bring in patients, well, now, before it was 3 days, now we bring them in 1 day before surgery, where they've already had their COVID PCR swab, and then they have one under admission as well. However, we don't do any more CT scans. If needed, they would perform an X-ray. You also mentioned the post-COVID that got postponed. It was after 12 days of quarantine, they were brought back in, and they had a negative swab and no obvious changes on their CT scan. However, as I mentioned in the presentation, later on, there was a patient that had a positive swab, but as discussed with virology, and they told us that this might be due to other reasons, and for debris or of the COVID infection that they might have had. So keeping all that in view, I think the main point here is to have a pre-screening, and ward segregation, I think, was our main point that that helped us continue with surgery.
We have a question from Henrietta Wilson. What is your protocol for urgent hospital transfer, like MPM or pneumothoraces? Do you test them? Do you amber them? Or can they be mixed with the other non-COVID patient?
So this would constitute an emergency transfer, which is discussed with the on-call consultant or registrar, and then they're tested at their hospital where they're being referred from. If they are negative, they are transferred to our hospital, where they're tested again, and we still have pre-op wards where transfers would also be admitted. So we are still segregating wards. We still have pre-op and post-op wards. So patients such as these emergencies would come to the pre-op wards.
I don't know if you have more questions from the audience. So I think we go for the next presentation.
Thank you.
Thank you. Very interesting.
Thank you. So our next speaker is James Acker, and the presentation is titled Patient Experience of Virtual Clinics in Thoracic Surgery. Should we continue following the pandemic?
Hello, my name is James Acker. I'm one of the cardiothoracic fellows working in the Bristol Royal Infirmary Department of Thoracic Surgery. This is an audio presentation of patient experience of virtual clinics in thoracic surgery. And by virtual clinic, we mean either a video consultation, telephone consultation, as opposed to inpatient, in-person, face-to-face consultations taking place in an outpatient department. Traditionally, outpatient appointments within the NHS has always been in person, and they are located within outpatient hospital departments. They cost about £153 per appointment, and total about £8 billion per year. Despite the fact that we have improved video conferencing technologies, outpatient appointments have doubled in the last 10 years. And this is having a significant impact on our environment. As a result, there is an NHS long-term plan to reduce outpatient appointments by up to a third, and this was made prior to COVID-19. The effect of COVID-19 has been to expedite this NHS long-term plan in order to reduce virus transmission rates. Within the Bristol Royal Infirmary Department of Thoracic Surgery, outpatient clinics are now almost exclusively virtual. The effects of switching to virtual clinics for our tertiary service are significantly improved patient convenience, saving time on travel and also expenditure related to travel. In terms of the healthcare service, there was significantly improved efficiency by reducing the amount of staff required for an outpatient appointment and also reducing travel times. This is our catchment area, and you can see that it spans a significant distance, and sometimes patients are expected to travel quite long distances. So we conducted an audit to determine whether patients were actually satisfied with our virtual clinics to inform us whether to make this change long term. This is an example of the technology used for video conferencing. This one is called Attend Anywhere. So the aims of our audit were to obtain subjective analysis of patient satisfaction with our virtual clinics to determine whether there were any issues that they encountered when trying to engage with the service. The inclusion criteria is any adult undergoing thoracic surgery seen in the virtual clinic prior to their appointment, and we conducted surveys between July 2020 and October 2020 of post-operative patients whilst they were inpatients. The N number was 47, 53 patients were asked to complete the survey, so this was an 88% uptake. The mean age was 68. 72% of patients had a telephone appointment, 27% of patients had a video appointment, 87% of patients felt that they were provided with reasonable pre-clinic information regarding how to access the appointment. 26% of patients had technical difficulties. 2 of these were related to sound quality of the video consultation. 3 patients had to switch from a video consultation to a telephone consultation due to an inadequate internet connection. And 2 patients had a poor telephone connection, which meant that there had to be a lot of repetition during the telephone call. So in terms of patient satisfaction, 90% of patients agreed with positive statements such as, I felt listened to, I felt able to answer questions when I wanted to, I felt the member of staff communicated with me clearly, I felt involved in decisions about my treatment and care. When asked if they prefer to have their appointment this way, 60% of patients said yes, and this is primarily due to time and money saved, whereas 20% of patients said that there's no substitute for face-to-face clinic appointments, and about 2 patients said that diagnostic consultation should always be face-to-face. About 20% of patients had no preference. When asked to rate their experience of having a virtual clinic appointment out of 10, 92% of patients rated it 7 out of 10 or more, and 40% of patients rated it 10 out of 10. When asked after the pandemic is over if they had a choice, do they think they'd prefer to have an outpatient appointment face-to-face or have it by virtual clinic appointment? 50% of patients said they would prefer to have a virtual clinic appointment, and 20% of patients said they would prefer to have a hospital appointment. About 30% of patients had no preference. In summary, there was very high patient satisfaction, with 92% of patients rating virtual clinic appointments at 7 out of 10 or above. The vast majority of patients would prefer to continue having virtual clinics following a pandemic due to convenience, particularly if video appointments are available. A minority of patients feel that face-to-face in-person interaction cannot be replaced and should not be replaced. And there were some technical difficulties with internet connection and telephone research which compromised the overall quality of some of our clinics. Many thanks for your attention. Any questions?
Great, thank you, James. That's a really interesting overview. Can I just start off by asking you one question? Did you look particularly into differences in what the appointment was for? For example, would something like Breaking Bad News be the type of clinic that you would be more inclined to offer a face-to-face appointment?
So we audited pre-operative patients, so any patient that had been through the diagnostic pathway and then were due to be seen by the consultant and delivered the news that they needed a surgical procedure, generally for their malignancy, although some pneumothoraces and empyemas would have been included in those. So Breaking Bad News consultations would tend to have been face-to-face consultations.
Yeah.
Generally.
Okay, thank you. A question from the audience, from Alan Dawson. How do you think the future of research might be if patients are preferring remote follow-up? It will be difficult to obtain research follow-up samples if needed, for example.
That's right. I think there always will be a place for in-person, face-to-face clinics. I think for thoracic surgery, where we have a sort of tertiary centre and patients have to travel long distances, a good example of what could be done is a video consultation with a consultant, and patients can then go to their local hospital and provide any samples, and things can be obtained that way to make the service a bit more streamlined. We felt, video and telephone clinics were particularly useful for tertiary services like thoracic surgery.
Great, thank you. And we're running a little bit short of time. I'll just ask one further question. Do you have any strategies for improving uptake of virtual clinics in those who cannot participate, either due to equipment or digital experience?
We haven't got any particular strategies at the moment. We did have some difficulties with patients who struggled with video conferencing, particularly because of their internet connection. And then some patients struggled with the telephone consultation because of the telephone coverage in their area, the mobile phone coverage in their area. So it's a difficult one. I think perhaps we have to liaise with the local hospitals for patients who have these clinic appointments, and perhaps they can have a room in their local hospital, which would at least save the consultant having to travel to the local hospital, which is what happens at the moment. Or possibly they can use a service at the local library or something along those lines if they're prepared to travel a short distance. That is a good question and something that we should look into.
Good, thank you. Thank you very much for your talk. If I could just remind the audience to rate presentations on the poll. Thank you.
So our next presentation is on Previd, the electronic end-to-bedogram successful video clips taken and uploaded by thoracic patients for preoperative assessment, and it will be presented by Dr. Kangi Chen.
My name is Connie Chen. I'm one of the anaesthetics registrars working in Bristol Royal Infirmary. I'm going to be doing my talk on Previd. This is a new project that we're rolling out in the hospital. This involves successful video clips taken and uploaded by thoracic patients for preoperative assessment. So Previd are short videos of thoracic surgical patients performing simple exercises. This allows a clinician to see a patient before meeting them in real life. It is a useful tool in preoperative assessment. We all know that a picture speaks 1,000 words. However, a video can provide extra information. It can provide fitness at a glance and also frailty at a glance. There is also quite a lot of evidence behind all of this. The initial clinical impression or end of bed assessment has long been valued as a highly useful tool. Recently, the evidence has begun to accumulate, which helps us to understand how this simple assessment can be useful. And these are just two articles that's been published in Anesthesia and JAMA in 2016. Clinicians can assess frailty, robustness, and the assessment can also provide information about mobilization, nutritional status, and cognitive function. Previd is a way to integrate this initial clinical impression so that all the clinicians can benefit from this useful information, regardless of whether they have met the patient. Essentially, the videos can help us to try to select the best treatment option for that individual patient as part of their preoperative assessment. Prior to the COVID-19 outbreak, the videos have been taken by preoperative nurses in clinics. However, there has been staff shortages, and there has also been a drive to reduce hospital visits during COVID. Through Previd, the videos can now be taken remotely by the patients themselves in the comfort of their home. This also minimizes COVID-19 transmission risk. The whole process starts from patients receiving the information and a consent letter as part of their preoperative pack before surgery. Once the patient has agreed to participate, they can sign the consent form and also upload a video of themselves performing these simple exercises. The consent form and video can then be uploaded onto www.previd.co.uk, and the files can be stored on the Secure Trust server. The videos can then be accessed as when needed by all team members of the preoperative assessment team, and also they can be used in the complex case review meeting, which happen weekly in the hospital. Feedback is collected throughout this process. We can improve and refine the whole process. This is just a short video demonstrating what the patient can expect. So once they receive the letter, there is a leaflet, again, outlining the entire project and also explaining the sort of exercises they would need to perform. And as you can see, the website itself can be accessed either through the QR code or the website www.previd.co.uk. Once they've accessed the website, it's very simple with clear instructions. The patient can then take a picture of their consent form and upload it, and along with the video recording of themselves performing the exercises. If there is any confusion about the whole process, there are film instructions and also demonstration videos showing how the exercises can be performed. So these are just examples of videos that's been successfully recorded and uploaded by the patients themselves. As you can see, they provide a lot of useful information which can be used in a preoperative assessment to formulate a management plan for these patients. So we have successfully recruited 16 patients and 11 have uploaded a pre-vid. All the patients felt safe and comfortable. Reasons for not uploading the videos including not receiving the information letters, and 2 patients were unable to upload the videos onto the system. All the comments have been positive. Patients have described the process as easy to understand and perform, and that this is the future. Other practical benefits including avoiding unnecessary trips to the hospital and also avoid travelling time. So in summary, we feel that the pilot has been a success, so we are hoping to expand the project and that pre-vid is a safe tool that will improve surgical risk management. The process of video recording and uploading can also increase the patient's engagement with their treatment. Other practical benefits including minimising hospital trips for those who are shielding or living in remote areas. To see the project or to see what the website is like, please do visit www.previd.co.uk.
Okay, that was a really interesting presentation, Dr. Chen. Whilst we're waiting for questions from the audience, I have a question. The patients, so with this pre-vid, the patients who couldn't upload video, so what would be the option? So do you bring them in? And do you, in this pre-vid scenario, is there a video showing the patients how to upload and everything? Because when we did video conferences, we struggled really like quite a lot getting patients to actually logging in. So uploading seems like a bit complicated for some people.
Yes, that is one of the problems we have been anticipating, and we've been gathering feedback throughout this process. Currently, because it's a pilot project, this is currently voluntary, so patients can participate if they would like to. And what we found is that actually most of the feedback has been positive, and the patients have found the process easy. The website itself has video instructions explaining exactly the exercise they have to do, and we also in the leaflet include equipment that the patient would need, and which is very simple, usually just a chair and a clock. So the exercise they do are just sort of sit to stand test and also walking test. Once they go onto the website, it has sort of stage to stage instructions on what they need to do to upload the videos. So what we found is that actually most of the patients have not had any issues so far.
Okay, so we have some questions. So one is, excellent work. Will it be extended to general surgery and cardiac surgery across Bristol? So probably someone from Bristol. Is everyone in the anesthetic faculty like using it? Do you like using this pre-vid?
Because currently it's a pilot phase, so we're just trialing it out in a small cohort of thoracic patients. And what we have found is that the clinicians have found the videos very useful. Currently, it has not changed any of the sort of surgical plans as of yet, but we're hoping as we roll out this project more sort of to a wider population, this may actually have impact on in terms of the planning. The videos have been also used in the complex case review meetings as a supplemental information on top of the other sort of preoperative assessment objective data such as FEPEX testing and lung function tests.
Did any of your previous submissions cause you to change your surgical plan or the plan for surgery?
So as I've said, currently they haven't changed any of the plans as of yet, but we're hoping that as we include more patients, it will probably have a more of an impact.
Okay, and the last questions, did you have any problems with data protection strategy, and where is the data kept?
So the data is kept in a central cloud, which is associated with the Trust server. So it's a very secure cloud, and the videos can only be accessed via password protected system. So only sort of clinicians with a permission who know the password can access such system. So the moment is very safe, and we work very closely with the IT department to currently sort of make sure that it continues to be safe.
Okay. Great presentation, really interesting one. So up to the next one.
Thank you.
So the next presentation, the impact of presence of COVID-19 on outcome in thoracic surgery service in a large tertiary center, presented by Megan Garner. And please don't forget to evaluate the presentation.
Hi, my name is Megan Garner. I'm a cardiothoracic registrar in the Northwest, working at Liverpool Hospital. Thank you for the opportunity to present our research on the impact of COVID-19 on the outcomes in thoracic surgery at a large tertiary centre. So we all know that COVID-19 forced significant changes in both the way that we assess patients pre-surgery and also how we manage them post-operatively, both in terms of separating out into clean and positive wards. There were also discussions around how we manage chest drains, certainly in case of the use of ambulatory bags and the risk of exposure whilst we're in the hospital. We had some informal discussions after the first wave, and there was a question about whether or not this had an impact on patients' length of stay or their management after surgery. So the objectives of the study were to look at how outcomes were impacted. The primary outcomes were length of stay and mortality as an inpatient, and the secondary outcomes included duration with the chest drain, duration with the PCA or paravertebral, and also readmission rates and post-discharge complications. In terms of our methods, we retrospectively analysed the data of all patients undergoing anatomical lung resection, and we excluded any other surgical patients. There were two groups. So the first group underwent surgery when we had patients in the hospital with COVID-19, and that was from March until the beginning of June. The second group underwent surgery when there were no COVID-19 positive patients within our hospital, and that was from the beginning of June until the end of July. In terms of the results were similar between both groups, both in terms of demographics and also in terms of length of stay and duration with paravertebrals and PCAs. The in-hospital mortality was similar, despite the risk of COVID-19 infection in hospital with the first group. And the readmission rates also were similar between the two groups. There was a slightly higher risk of complications at follow-up. However, it's worth noting that the majority of these complications were chest infections or wound infections, and there were no serious complications found at follow-up. So in terms of our results, both groups were comparable in terms of their outcomes, and there certainly appears to be no difference in terms of length of stay or in-hospital mortality based on how we process patients at Liverpool Heart and Chest. In addition, there was no increase in readmission rates during this period either. So we can suggest that the policies that were put in place in Liverpool, which were predominantly having clean wards completely separate positive and negative outpatient, inpatient wards, had an impact on reducing the transmission, and also meant that we were able to continue providing an adequate lung cancer service during this period. Thank you very much.
Thank you very much. It's a very interesting presentation. What was your pre-admission criteria to prevent COVID infection? Were the patient admitted to the cubicles, or was they were self-isolating before? What was your protocol?
So our protocols are the same as Hamad presented earlier. So every patient needed a negative swab before admission. So initially, I think that was 48 or 72 hours before admission, and they also then have the CT scan when they came into hospital, which we started doing initially, bringing them in 2 days before, and then that gradually dropped to 1 day before when we managed to get more space with the CT scanner. And then as it's gone on, it's changed to X-rays, and now it's a swab, a rapid swab, when they come in the day before.
And because you were doing some tests when the patient were admitted, was they admitted in the green zones straight away, or they were amber and moved to green after the test?
So in Liverpool, we have 3 main surgical wards. The ward that we usually use for thoracic surgery became a preoperative ward, and all of the post-op patients then went to one separate ward, which then became a mix of cardiac and thoracic surgery. So until someone had a negative swab, they were isolated on one particular ward.
We have one question, anonymous question. Did you have any COVID positive patient post-operatively, and if so, what were the outcomes?
So the outcomes are the same as Hamad presented earlier. So we had a number of patients that tested positive post-operatively. Initially, with the first wave, the outcomes weren't particularly good. We had a lot of mortalities, particularly in terms of people that were readmitted to hospital with COVID-19 after they'd been initially discharged. The second time around, and particularly, we picked up a lot more asymptomatic patients in terms of BAL positive. And actually, those patients did remarkably well. Initially, we kept them for quite a few days after discharge, after their operation, mainly to monitor for any symptoms or any complications. But actually, their length of stay would have been the same as any other patient that had undergone lobectomy at that time.
I think we have no more questions. I think we should proceed to the next presentation. Thank you very much. Very nice presentation.
Thanks.
Thank you. So our next presenter is Rebecca Fraser, and the topic of her talk is predictive validity of lymphocyte counts in patients with suspected COVID-19 infection in the early post-operative period.
Good afternoon. My name is Rebecca Fraser, and I'm currently an FY2 doctor based in Leicester. I'm presenting today our research on the predictive validity of lymphocyte counts in patients with suspected COVID-19 infection in the early post-operative period. This research is the result of a multi-site collaboration between the University Hospitals of Leicester, Birmingham, and Nottingham. There have been over 132 million confirmed cases of severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 infection. The global COVID-19 pandemic continues to overwhelm healthcare systems internationally and has resulted in an unprecedented impact on routine thoracic surgery care. Our understanding of the mechanisms, clinical features, and prognostic indicators of this novel respiratory virus are improving rapidly but remain severely limited. Early diagnosis may contribute to reducing associated morbidity and may limit the risk of cross-infection to other patients, particularly in the context of emerging evidence of beneficial therapy, such as dexamethasone. The current gold standard diagnostic test, as per the World Health Organization, is the reverse transcription polymerase chain reaction, or RT-PCR swab test. This test, however, has a relatively long turnaround time, it's expensive, and has high rates of false negative result. We also have diagnosis using cross-sectional imaging of the chest, which demonstrates high sensitivity in symptomatic patients, but overall low specificity. Emerging evidence also suggests that generic hematological testing may play a role in the diagnosis, whilst also predicting clinical course and severity. Lymphopenia is the most consistently reported abnormality, being both associated with COVID-19 infection and predictive of poor outcomes. Lymphopenia is also a feature of the usual post-operative course in patients after major surgery, and has previously been shown to be independently associated with surgical site infection and pneumonia, as well as being a predictor of poor survival. Whether lymphopenia is a useful indicator of SARS-CoV-2 infection for patients in their perioperative period is not known. Our methods show that we designed this prospective multi-center case match study to assess the predictive validity of lymphopenia as a marker of COVID-19 in the early post-operative period. All adult patients undergoing thoracic surgery in 3 specialist units between the 1st of March and 31st of May 2020 were eligible. All consecutive patients with PCR swab confirmation of COVID-19 diagnosis up to 77 days prior to or 14 days following the index procedure were included. The control group was determined on a consecutive 4-to-1 case matching basis by identifying the 2 patients who underwent the equivalent surgical intervention immediately before and after the COVID-19 positive patient. Patients with known immune deficiency syndromes and pre-existing hematological malignancies were excluded. Lymphopenia was considered firstly as anything below the normal range, and secondly in categories of severity. Statistical analysis was performed in Stata version 16. In total, we had 11 patients who were identified to have a confirmed diagnosis of COVID-19, and 8 patients were included in the analysis, as 3 patients underwent major complex intervention without appropriate matched cases. Fisher's exact test demonstrated a statistically significant association between patients with COVID and fever, with a p-value of 0.031, and severe lymphopenia, with a p-value of 0.037. Sensitivity analysis failed to demonstrate any strong predictive benefit of any of our parameters in isolation outside of fever and lymphopenia. However, this is likely strongly limited by our very small population. Hematological ratios may have benefit for diagnosis. In conclusion, additional parameters such as neutrophil or platelet lymphocyte ratios may be discriminatory, but additional work is required. However, it's clear in our population that even though lymphopenia is usual in the post-operative course, severe lymphopenia is still predictive of COVID-19 infection in this cohort. These are our references. I'd like to thank all of my co-authors involved in the gathering and analysis of this data, and thank you for your time in listening to this presentation.
Thank you, Rebecca. That's an interesting presentation, slightly different to the previous topics we've heard before. While we're just waiting for some questions to come in from the audience, I'd be interested to know, firstly, did you just look at lymphocyte counts in post-operative patients, or do you think this is something that could be used as part of the screening or triage for pre-operative patients?
Yeah, so it's a great question. I mean, I think the focus of this, I suppose, was in the comparison between the lymphopenia that we see normally in post-operative patients and whether or not there's a difference in the COVID population. And I don't know if there's any data on whether or not the lymphocyte counts would be lower pre-operatively, or if that would be almost too far in advance, if that makes sense. But certainly worth something looking into, I think.
Thank you. And my other question was around, I think you said there were 11 patients tested positive, 8 were within the study. What were the outcomes of those patients? How did they do?
So I think from what we looked at in this study, actually it was only sort of a couple of weeks that I've looked at within this study, and the people who were COVID positive within these sort of 7 days post, all of them survived, and in terms of their longer term morbidity and mortality, I haven't got that data, I'm afraid. I'm not sure what their outcomes were further on from there.
Okay, thank you. And a question from one of our co-chairs. What do you think the implication of your work is on our current practice?
Yeah, great question. I mean, I think that as treatment of COVID infection becomes more and more evidence-based, we have more and more research about how to treat it. I think what what this study is trying to look at is how we can predict it in a way to treat those people early. It's effectively how we can triage people, isn't it, to try and catch infections earlier so that we can then effectively isolate people, start treatments early in order to prevent any kind of future morbidity and mortality in that sense.
Thank you. I think that's all of our questions. So thank you for your presentation. We'll move on to the next speaker.
So the next presentation is is telemedicine an effective means of providing remote clinical services, and it will be presented by Kudzai Kotiwaya. Apologies if I didn't pronounce it correctly.
The title of our presentation is telemedicine an effective means of providing remote clinical services? We carried out our survey in a thoracic surgical unit. On January 29, 2020, the UK reported its first 2 cases of coronavirus. The following day, the WHO declared a global state of emergency. Almost 2 months later, the UK entered its first lockdown. The outbreak of the COVID-19 pandemic has caused severe disruption to healthcare delivery across the country and globally. Lockdown and social distancing rules have sorely limited the capacity of conventional face-to-face consultations. With little to no preparation, virtual clinics were implemented across the National Health Service, more so out of necessity rather than convenience. We thus undertook a survey to evaluate patient experience and overall satisfaction with telemedicine in a demographic where technology adoption is historically low. The average age for a thoracic surgical patient in the UK is 62 years. The GMC has a decision-making tool to help determine whether a remote consultation will be appropriate for a patient or not. This tool was available prior to the onset of the pandemic. We designed a survey to help evaluate these factors, which we sent out to patients via a postal invite. We encouraged returns either as a paper form return or a web-based link. The overall response rate was 46.2%, with a brunt of the respondents returning them postally. The majority, 56%, were female. Close to 70% of the respondents were above 65 years of age. Part of the factors we looked into were to determine not only the usefulness, but the safety of virtual clinic reviews. This involved inquiring whether patients felt happy with regards to the amount of time they were given to express their concerns, and whether they felt they were given sufficient information with regards to their medical condition and the further treatment they required. The results, as shown in this table, were predominantly positive. We also looked into the time factor involved on the patient side with regards to the amount of time they needed to commute to hospital for a clinic appointment and the amount of time they spent in hospital for an average clinic appointment. More than 55% of patients required at least half an hour to travel to hospital, and about 37% of patients needed between 1 to 2 hours of time within the hospital for their clinic appointment. Overall, about 47.2% of patients felt they were quite happy to carry on with the virtual clinic appointments for routine clinic reviews. In conclusion, routine clinic follow-ups can be safely conducted virtually. Video consultations help improve patient engagement and experience. Accommodations do need to be made for patients with disability. Thank you.
Thank you for your presentation. Whilst we were waiting for audience questions, I have a question or two. So my question is, did you feel, because when we did video consultations, before COVID, when we did any consultations, most of the time for lung cancer cases, we would have a lung cancer specialist nurse with us, and it would be kind of like a small NBT kind of a discussion. But even pre-surgery and post-surgery, when we are telling them their final histopathology report and doing the further discussion. So did you feel, from your point of view and also from the patient's point of view, did you feel that there was any difference in how that was maintained, like when you're calling them? So did you have your cancer nurse specialist, or did it make it difficult, or was it okay?
Okay, thank you. The main focus for our survey when we conducted it was looking into follow-up patients in our clinics. It wasn't necessarily for new patients presenting new in the clinics. And so we didn't face that much challenge in that regard. But as a result of the findings that we got from our survey, the vast majority of the patients did suggest that a video consultation would be more engaging, and that was a part of what we were trying to implement locally, as to do more video consultations, and this would be more helpful. Apologies. This would be more helpful for new clinic visits. So the platform that we were planning on using for our new clinic follow-ups would accommodate for that, where you would have either a consultant, a thoracic specialist nurse, and one other person to be present, and it could almost be like a score or a mini MDT, as you alluded to. So I think a video consultation would help exceedingly in that regard. And as previously alluded to by the previous speaker about Previd, I think that was the main drawback in using just virtual consultations for a patient being considered for surgical intervention. And so if you can get over those hurdles, I think virtualizing clinics both for follow-ups and new patients would be the way to go.
Okay, so we have a question from Mr. Marchbank. So do you still ask for chest X-ray or other tests at follow-up? And if you do, then how would you manage that if this is a telehealth or a virtual follow-up visit?
Yeah, so especially for lung cancer follow-up, so we do request a standard, either a chest X-ray or a CT scan. So if patients will be coming back to the main hospital, which is Leicester, which is their routine follow-up, we would ask them either to come into hospital for just a chest X-ray, either a day or two before their actual clinic appointment, so that the clinician, whether it be the registrar or the consultant, can actually view the imaging before the actual clinic date. The same applies for CT scan. So if, for example, you would see a patient in the clinic setting and recommend a CT scan prior to the next review, the thoracic specialist nurses will then arrange for a patient to have the appropriate, renal function test before the CT scan, and then come into hospital for the CT scan before their actual clinic date.
Okay, thanks a lot. So on to the next presentation. Thanks.
Okay, thank you.
So the last presentation of this session, but quite interesting. It's in unusual radiological findings in COVID-19 pneumonia. Is there a need for surgical intervention? And presenter is Cameron McCann.
First of all, thank you for inviting us to speak about our research project about the unusual radiologic findings in COVID-19 pneumonia. Is there a need for surgical intervention? There are no disclosures of any of the authors. we can tell that the CT findings of COVID-19 pneumonia have been reported widely. However, the pulmonary pneumatoceles, which are parenchymatous thin-walled air-filled cysts, which might happen after the chest infection, are not reported that widely compared to the other findings. We can see from this paper that GGO and consolidation are the most common CT findings in COVID-19 pneumonia, and the most valuable features are parallel pleural sign and paving stone sign. However, only 2 cases in that series out of 130 patients developed pneumatocele. In this presentation, we will show radiologic images of 3 patients who had COVID pneumonia proven by the PCR test, and they later on developed pneumatocele. All of the 3 patients actually followed the same pattern of having COVID pneumonia at the start, and then after discharge or later on, they developed this pneumatocele not at the initial presentation of the COVID pneumonia. The first patient is a 67-year-old gentleman with nil post-medical history. He had a conservative management of the COVID pneumonia by oxygen and antibiotic, and later on, after discharge, he presented with shortness of breath, hemoptysis, and CT scan was done, which showed pulmonary embolism and this picture of pneumatocele versus encysted pneumothorax on the left side. Actually, the multidisciplinary discussion about this picture and about the discussion, is there a need for surgical intervention or conservative management should be tried in that case, was done, and the decision was to do CT-guided intracostal drain insertion on that, in that encysted empyema versus pneumatocele. And because of difficulty in the insertion of that drain, the procedure was abandoned, and the X-ray after the procedure showed some degree of well-formed pneumatocele. We can see here on both sides. And after that, conservative management were continued for that patient and until he was discharged home safely, and follow-up chest X-ray showed complete resolution of that pneumatocele following recovery. The second patient is a 71-year-old gentleman with a nil post-medical history. He presented with a severe COVID pneumonia and required CPAP and later on invasive ventilation. He developed AKI and renal replacement therapy was tried as well. And we can see in the X-ray here, there was a radiologic finding of either encysted pneumothorax or pneumatocele on the left side, just adjacent to the chest wall, and the similar pattern on the follow-up chest X-ray there was no cardiac compromise or any tension effect of this cyst, and on follow-up chest X-ray and CT scan there was well-defined pneumatocele on the left side, and in the CT scan we can see without any intervention there was no need for that at the start, and only conservative management was indicated in that case. The third patient is a 47-year-old gentleman with a nil post-medical history. He presented actually with a respiratory failure, and he was ventilated from the start. And we can see that severe pneumonia bilaterally in that case. And because he developed a tension pneumothorax on the left side, he had a chest drain inserted. And on follow-up chest X-ray, actually on the discharge, we can see a large pneumatocele on the right side, which was managed conservatively after that. And we can see on follow-up CT scan, almost in the fissure, encysted pneumatocele versus encysted pneumothorax were found bilaterally, which was later on follow-up CT scan showing obliteration of these cysts by fluid. So we can tell that 2 of 3 patients required invasive ventilation. Invasive ventilation might cause pneumatocele, but the common trend among these cases is COVID infection. 1 case was initially considered for surgical intervention. However, gradual resolution was observed without surgical input. And pneumocele can present as a delayed complication of COVID-19 pneumonia. Surgical intervention, we can tell, should be considered only if there is cardiorespiratory compromise, and conservative management should be always the case in our approach. And we can see here final, image of our first patient, second patient, and the third patient, which was all of these were picked up in the CT scan. So in our small cohort, we can tell that pneumatoceles were discovered in the resolution phase of COVID pneumonia, and they were picked up incidentally. And we prefer to start a conservative approach first with the oxygen and antibiotic, and only consider the surgery if there is a cardiorespiratory compromise. Thank you.
Really a very interesting presentation. I think we all learning. There is a lot of unknown about how to approach COVID, and this is an example that maybe we should be more conservative than aggressive. Thank you very much for the presentation. Do we have any question for the audience?
Thanks.
I think we have one question. What would be the surgical management of the pneumocele?
Pneumocele. So can you hear me right now? Is that okay?
Yes.
Thanks. So actually, this our case reports, showed a couple of patients with pneumoceles. All of them were referred for a surgical intervention, and only one of them, chest drain insertion was tried. And most of the time, just conservative management of pneumatoceles usually is applied in that cases. And only surgical management if there is any tension pneumothorax, if there is a large pneumocele, or if there is a suspicion of being an emphysematous poly rather than encysted pneumothorax. All of these are indications for intervention. And on the longer term, or you can say the intermediate term follow-up of our cases, actually we have seen that a couple of patients with pneumocele at the initial presentation complicated with encysted empyema after that, and two of them actually had decortication. But this we will present in our paper, which will be published very soon, hopefully. So this, either if there is a complication, super added infection in that cases, if there is a tension pneumothorax, all of these might be an indication for intervention. Otherwise, we just follow up them conservatively.
Especially, I think that this patient are not in a very good general condition. So I think more conservative approach is most probably beneficial.
Exactly. One of them you can see was intubated at the start, and the other was just CPAP was followed with them. So, the clinical data are very important to judge on the best management in that case.
We have another question from the audience. We were referred a large number of patients with pneumomediastinum. What's your experience, and where is this managed?
Yeah. Our actually scope wasn't about the pneumomediastinum. It was about just pneumocele. But I can tell, even for all the referrals, it's very common to see all of that. Me personally got at least 5 to 6 patients with a pneumomediastinum since the start of the COVID, especially in the second wave of the COVID. I don't know. It might be related to the severe cough such patients has. During the episode, but we didn't go further for investigating that cases. Our scope was just concentrating on the pneumoceles. But most of the time, conservative management for the pneumomediastinum is followed, and resolution usually follows that.
We have just some information from Stephen Kasai. He thank you for the moderated and also presented. He finds that this session was very interesting and very, very important, and he's looking to be and see in person maybe next year in SCTS 2022. And I think it's all what we wish, that we meet together. I really, I can thank you all presenter and my colleagues to co-chair this meeting. I think it's important. We're still in the learning phase, and this is a very important to learn from the colleague how to manage in this difficult time of COVID. Thank you very much for your participation.
Thanks a lot. Thanks everyone.